Well, hello everyone, and welcome to this webinar focused on the treatment of heart failure in 2021. This webinar has been sponsored by Servier and is being hosted by EMG Health. My name is Dr. Jonathan Sakia, and I serve as the chairman of the Medical Advisory Board for EMG Health, and I'm very proud to be your moderator for today. This is an extremely exciting time for those interested in heart failure, with new and positive clinical trials of emerging treatments and a robust rethink about treatment sequencing following on from the last Heart Failure Association Congress. So this is a perfect opportunity to hear from the leading authorities in the field, and we have presentations by three distinguished, accomplished, and renowned experts. Kicking off is Professor Michel Komajda, Emeritus Professor of Cardiology at the Sorbonne University in Paris. He was also head of the Department of Cardiology at the Salpêtrière, apologies for my awful French pronunciation, hospital, and that was also in Paris. And he'll be providing us with some vital context, exploring how patients with heart failure are currently treated by investigating data from Qualify and other registries. Then we'll hear from Dr. Carolyn Lam, who's a professor at Duke National University of Singapore and senior consultant at the National Heart Centre of Singapore, who will give us her thoughts on the current heart failure spending function challenges in the implementation of guideline-directed medical therapy, or GDMT. We shall then conclude with a presentation from Professor Michel Bohm, Director of the Clinic for Internal Medicine and Chief of Cardiology at the University of Saarland in Homburg-Saar in Germany, will wrap up with his fascinating perspective on how we can personalize the approach to heart failure therapy in the future. Following our speakers' presentations, we'll be coming together for a live question and answer section. So please do post your questions throughout in the Q&A box, which you will see at the bottom of your screen. Look for that. I look forward to posing these to our experts at the end, and we shall do our very best to address as many as possible. And with that, I will hand over to our first speaker, Professor Michel Komajda. Professor, the floor is yours.
Thank you very much, Jonathan. Good morning, ladies and gentlemen. So my role today is to review recent registries in order to see how patients with heart failure and reduced ejection fraction are treated. You can see my disclosures on the bottom of this slide. And I would like to start by the rate of prescription of guideline recommended medications. Let's start with the ESC heart failure long-term registry. If you focus on the middle column, which is reduced ejection fraction patients, it seems that the situation is rather satisfactory, since ACE inhibitors and ARBs are prescribed to 92% of the patients, more or less so for beta blockers. 2/3 of the patients are receiving a mineralocorticoid receptor antagonist. So it seems that the rate of prescription, once again, in this European registry is rather satisfactory. This is another European registry, the Czech HF registry, which was conducted in 34 Dutch hospitals. And if you look at the blue bars, which are for FREF patients, here again, there is a rather good rate of prescription because RAS inhibitors were prescribed in approximately 85% of the patients, exactly the same for beta blockers, and MRAs, again, around 60%. Now, there is some difference based on the situation. Here again are data from the ESC registry. If you look at patients who have worsened and been hospitalized on the left-hand panel, obviously there is a progressive increase in the rate of prescription of recommended medications from pre-hospitalization to in-hospital situation and 1 year after discharge. Whereas in outpatients, it is the right-hand panel in blue, virtually no change occurs regarding the rate of prescription of these heart failure medications. There are also some patient-related factors which influence the rate of prescription. This is the rather old now Euro Heart Failure 1 survey, and I took the example of beta blockers once again. You can see that in patients with an history of respiratory disease, the likelihood of receiving a beta blocker was significantly reduced. On the contrary, if these patients had an history of ischemic heart disease, they were more likely to be prescribed a beta blocker. And if they were in cardiology and not in internal medicine, it was exactly the same situation. Finally, age above 70 years was associated with a reduced likelihood of receiving a beta blocker. And this shows again in the Czech HF registry, where they looked at the rate of prescription of loop diuretics, RAS inhibitors, beta blockers, and MRAs by age class. And you can see that for all classes but diuretics, octogenarians, which are shown in yellow, are less likely to receive any of the guideline recommended medications. So at this point, we can say that overall from European registries, the rate of prescription seems rather satisfactory, but that there are variations which are related to age and to patient condition, including comorbidities. Let's move on to dosage. And here the situation is less optimal. This is again the ESC heart failure long-term registry. And you can see that only 30% or so of the patients were at target dose for ACE inhibitors, less than 20% for beta blockers, and 1/4 of the patients for ARBs. This is confirmed by the Czech HF registry. And by the way, if you look at the upper part of this slide, you can see that there is a significant variation in the rate of prescription between these different hospitals. But if you look at the two pie charts outlined in red, you can see that approximately 1/4 of the patients treated by ACE inhibitors or ARBs were taking less than 50% of the recommended target dose, and approximately 45% for beta blockers. So there is underdosing of these classes. What did we learn from the Qualify registry, which enrolled 7,000 patients in 36 countries around the globe? And I take here again the example of beta blockers. If you look at the pie chart, the rate of prescription is rather satisfactory, 87%. And in the 13% who were not taking a beta blocker, the number one cause for not being prescribed was poor tolerability. But if one looks at the circle in red at the left part and the bottom part of my slide, you can see that only 15% of these patients were at target dose, and approximately half were taking at least 50% of the target recommended dose of beta blocker. And indeed, we did an analysis with Professor Martin Cowie from London in order to see whether there were some predictors of reaching the target dose or not. And indeed, there are a number of factors which are associated with the ability to reach a target dose. For ACE inhibitors and ARBs, for instance, the existence of chronic kidney disease is associated with the reduced likelihood of having these classes of medication. On the contrary, diabetes mellitus or hypertension are associated with an increased likelihood. For beta blockers, a higher age is associated with a lower likelihood. And on the contrary, once again, diabetes mellitus and hypertension are associated with an increased probability of being treated by a beta blocker. For MRAs, not surprisingly, the existence of a chronic kidney disease is associated with a lower probability of receiving an MRA. And finally, for ivabradine, age is associated with a lower probability, whereas asthma or a high resting heart rate are associated with an increased probability of being treated by ivabradine. This slide, coming again from the Czech HF trial, highlights the role of age in the probability of being at target dose. Target dose is shown in green and 50% or more in orange. And you can see that for beta blockers, RAS inhibitors, and MRAs, the class of age of 75 years or older is associated with a lower rate of high doses of these heart failure medications. There are also geographic variations, which we do not really know why it is so. This is the case for ACE inhibitors and ARBs on the left-hand panel, beta blockers on the right-hand panel. Obviously, the champions in terms of reaching the target dose are Scandinavian countries, whereas other important European countries, there is a variation where, once again, it's not very easy to find a clear explanation. Finally, we looked at, in the Qualify registry, at the changes with time in dosage. And this is again a study made by my colleague, Professor Kawi from London. And you can see that there are some individual variations in the dosage, but on average, very little changes with time. And we had a follow-up of 18 months. This holds true for beta blockers, MRAs, ivabradine, ACE inhibitors, and ARBs. So it seemed that for this outpatient population, physicians do not try to uptitrate medications, although in many instances, the dosage is far from being at target. This is very much in line with other registries from the US. I let Professor Lam speak of Asian registries. This is the Pinnacle registry, which enrolled more than 11,000 FREF patients. If you look at the blue lines for beta blockers and ACE inhibitors or ARBs on top, MRAs on the bottom, these were the patients who were taking less than 50% of the target recommended dose. And you can see that very little happens because the curves remain flat from the worsening event to 6 months later on. And another US registry, the CHAMP Heart Failure Registry, shows similar results. Here again is the case of beta blockers. You can see that there is very little variation in the dosage of beta blockers provided to these patients with time. What is the impact of this subdosing of heart failure medications on clinical outcomes? The first example comes from the Biostat CHF registry, which was conducted in Europe. And you can see that the probability of dying in this European population was much higher in those patients not treated by ACE inhibitors or beta blockers in red, or receiving a low dose in green, compared to those at target dose or at the dose of more than 50%. The other example which shows that there is a clear impact on clinical outcomes comes from the Qualify registry. In Qualify, we constructed a score which takes into consideration not only the rate of prescription in FREF ambulatory patients, but the dosage reached, and the score optimally was 1. And you can see that there is a significant difference between patients who had a good score, the dotted blue curve, in terms of heart failure deaths or heart failure hospitalization or cardiovascular deaths, compared to those patients who had a lower adherence score, and this was mainly due to a lower dosage of heart failure recommended medications. What are the factors of poor adherence to guidelines? Of course, comorbidities or side effects play a major role. There are also some contraindications to some of these medications, but there are some factors which might be corrected, which relate to patients' reluctance or lack of awareness of the objectives of the treatment, or the physician's reluctance or lack of awareness of the objectives of the treatment, and some GPs concentrate on reduction of symptoms and not in improvement in clinical outcomes. The organization of healthcare systems after discharge is also involved. In particular, there is a sort of inertia when patients leave the hospital if something is not planned ahead of time. Economic factors may play a role because some medications are expensive. And finally, social factors, including isolation or cognitive disorders, may play a role. Finally, what are the solutions for the future? One important solution is to develop disease management programs, such as the optimized heart failure care supported by Xavier, in which you have a multidisciplinary approach, including checklists before discharge in order to be sure that patients will be seen shortly after they have been discharged from the hospital. Patient education is key in order to explain clearly the objectives of the treatment, early initiation of life-saving drugs, we are going to speak of that later on, and finally, telemonitoring may play a role in improving this situation. I would like to thank you for your attention, and I will now hand over to my distinguished colleague, Professor Carolyn Lam from Singapore.
Thank you so much, Professor Komajda. It's my distinct pleasure now to expand upon what Professor Komajda has just said and maybe dig deeper into the challenges of implementation of guideline-directed medical therapies in heart failure, and also perhaps examine what's the latest recommendations on how we initiate and up-titrate these medications. Here are my disclosures. So picking up from where Professor Komajda left off, let me talk a little bit about Asia. And here are results from our Asian heart failure registry across 11 regions in Asia. And I hate to say, but the results are basically very similar, although there are not too bad uptake with 77% of patients who should be receiving ACE inhibitors receiving it. Only 17% are receiving the drugs at guideline recommended doses. And there's a huge variation across Asia where doses seem to be lowest in China and Japan and highest in Indonesia and South Korea. If we look at beta blockers, it's the same picture, but now only 13% are receiving guideline recommended doses. And again, very interesting patterns where in particular, there's the highest uptake, but at the lowest mean doses in Japan. Now, I'd like to share though, some newer information about these combination of doses. Now, if you look here, what we're showing here in all these columns are the hazard ratios for an outcome of either death or heart failure hospitalization, so that the lower the bar, the more protective the effect we assume we are seeing, although these are observational data. Now, if we look now at the two axes, what we looked at is the association of different doses of beta blockers and ACE inhibitors with outcomes in our Asian heart failure registry. Now, as you may expect, right in the apex in the front would be those on the 100% guideline-directed doses of beta blockers and ACE inhibitors, and they had the lowest risk of the outcomes. However, what I do want everyone to note is that the perimeters, which are up titration of only ACE inhibitor or only beta blockers, you can see that the risks are all higher than if you have lower combinations of beta blockers and ACE inhibitors. So a very interesting, albeit observational study to suggest that lower dose combinations may be better even in a real world setting than high dose of only a single drug. Now let's put it all together, and these are all the different registries and observational studies that have looked at adherence to guideline-directed medical therapies in the real world. You can see it's all over the map and not looking very good. Maybe okay for beta blockers and ACE inhibitors, and then really, really falling off the map for all the rest, including ARNI, MRA, and ivabradine. Now, if we look into the reasons for non-adherence to guideline-directed medical therapy. This is a beautiful study that looked just at that and really tried to dissect the reasons for the undertreatment or even the lack of optimization. Here, first, I want you to notice in the circles, those who are at the guideline and proper doses. And you can see it's dismally low for beta blockers, ACE inhibitor, MRA, but even lower for ivabradine, which means we're not giving patients who perhaps should be receiving this medication. We're really, really undertreating them. And then if we look at the why, the physiological limitations that are highlighted in red are a major reason for the beta blocker, ACE inhibitor, and MRA underuse. As you can see, 25% ranging down to 11% for MRA. What do we mean by that? It means blood pressure or heart rate or renal function limitations that really make it impossible for us to actually increase the dose safely in these patients. However, look for ivabradine. It's only actually a 5% limiting in physiological reasons. So there are many reasons, but sometimes I think we can't just say that it's because the patient can't tolerate it. And why do we say that patients can't tolerate it? Is it really such a big problem? Well, it is true that we are treating an increasingly older and comorbid population when we're thinking of heart failure. And these are just some magnificent data from the UK that show that the patients with heart failure are having more and more comorbidities. One that really needs to be highlighted is, of course, chronic kidney disease, which then limits our use of ACE inhibitors and ARNIs and MRAs. The current ESC guidelines of 2016, in fact, really highlighted this important impact of comorbidities. And really in number 4, you can see here, really clearly state that it may affect the use of treatments for heart failure, but also vice versa. Heart failure treatments can affect the treatment for the comorbidity. Again, just focusing on what we're doing now in the 2016 guidelines and why we need a change. Well, this is a very famous figure from the 2016 guidelines for HFrEF treatment. And you can see it goes in a sequential approach where you start with an ACE and beta blocker, up titrate. If the patient is still symptomatic, then we add an MRA, up titrate again, and then so on and so forth. Now, why did we recommend something like this? Well, it's because it was informed by historical trials. But we're now really questioning this for several reasons. First, we see, and we've seen from both my data as well as what Professor Komajda presented, that it doesn't happen in real life. And it really takes a very long time to achieve optimal therapy if we keep doing this sequentially like this. Next, if we ask ourselves, is there evidence that the most effective or well-tolerated treatments were developed first? The answer is no, because we had the paradigm trial that clearly, for example, showed that the ARNI trumped the prior treatment, which was the ACE. So it's not that the first drugs that were developed were the most important or the most effective. We know now that delays in initiation of effective therapy results in avoidable events. And we've got plenty of data showing that in the new trials, for example, with ARNI, the curves separate very early with SGLT2 inhibitors. I've just shown you data that low doses of guideline-directed medical therapy yield important benefits. So that really makes us question, why should we up-titrate one and sacrifice the others? Next, and of course, is because we've kind of broken the model of this historical approach, because the newer trials of SGLT2 inhibitors, for example, were conducted simultaneously. In the very SIGWAT trial, there was very, very few patients on ARNI, much less SGLT2 inhibitors, for example, and they were all conducted simultaneously. Regardless, the available evidence suggests that the magnitude of treatment benefit of each new class is independent of the others and occurs early. So it only makes sense that we flatten the approach. And these are the 2021 update of the consensus decision pathway from ACC and AHA, not the guidelines, but a decision pathway. And you can see now, although ACE, ARNI becomes right on top and beta blockers are there, the rest become flattened out with MRAs, SGLT2 inhibitors, diuretic, hydralazine, ivabradine, all in the same row, meaning perhaps now we should not wait to initiate, we should consider all these therapies. Now, in this guideline, though, they do say serial evaluation, titration of medication that takes quite some time. Well, guess what? This has been questioned even more now with a proposed new sequencing, suggesting that we should get to the right combinations of the core drugs of beta blockers, SGLT2 inhibitors, ARNI, and MRAs within 4 weeks in a patient. Now, the sequence, frankly, you can tell the conventional sequencing, the proposed new sequencing, you'll hear about a lot more sequencing. I think what we should really take away from that is the principles of it, because if not, we'll get ourselves all tied up when we see these patients, which is there are 5 pathways now that improve mortality in our patients with HFrEF. And these 5 pathways can be targeted with 4 drugs, which are the basis, the ARNI, beta blocker, MRA, SGLT2 inhibitor. The key is to try to get every patient on these 4 drugs, even starting at low doses first, as fast as possible. But then I really want to focus on the 5 others, which I think in this day and age, when we're talking about this fabulous 4 and so on, we tend to forget about the other options available to us. Now, with these 5 additional pathways, which specific populations should we be thinking of adding these new drugs? Well, I'd like to start right on the top with ivabradine. Now, we know the results of the SHIFT trial. It was a positive trial showing that ivabradine reduced the primary composite outcome of cardiovascular death or heart failure hospitalization compared to placebo. However, if we examine which are the patients that especially benefit from this approach and whom we should really not miss out giving them this medication, these would be patients, for example, from this beautiful analysis from Dr. Bohm, of heart rate. And here, showing patients with a heart rate above 75 beats per minute, you can see clearly all the outcomes are improved with ivabradine compared to placebo. And this includes cardiovascular mortality. If we look further, does the presence of renal dysfunction affect the benefit with ivabradine? Well, the clear answer is no. If you look at these curves, the blue represent placebo, the orange represents those treated with ivabradine, the solid lines are those with kidney dysfunction. You can see while they have a higher event rate, it's still lowered with ivabradine. And in those with no renal dysfunction, they still benefit with ivabradine. So regardless of renal dysfunction, ivabradine is beneficial. What about systolic blood pressure? Well, in this beautiful study from Dr. Komajda, who looked at bins of systolic blood pressure at baseline, whether it is low, middle, or even high in those with above 130 millimeters mercury, you can see there's consistent benefit with ivabradine compared to placebo on the primary endpoint. And now in this very clever study, looking at the SHIFT trial and looking at patients who during chronic treatment with ivabradine were hospitalized, you can see that the effect of ivabradine on reducing early admissions after hospitalization in that vulnerable phase is very clear. At 1 month post-hospitalization, there's already a reduction in events. And so in summary, if we put this together, it does appear that in especially patients in sinus rhythm with a high heart rate, ivabradine should be strongly considered regardless of systolic blood pressure, regardless of renal function. And it's important to think of it early because it benefits patients early after heart failure hospitalization. Now, what if we look at the Victoria and Galactic trials in the same way? As a reminder, the Victoria trial was a positive trial as well in patients with recent worsening heart failure, meaning within 6 months of a heart failure hospitalization, where vericiguat compared to placebo reduced the primary composite of cardiovascular death or heart failure hospitalization. Now, which subset? Well, perhaps those with a baseline NT-proBNP not too high, right? So the effect is emphasized in those with a baseline NT-proBNP less than 4,000, going up to 8,000. But when the baseline NT-proBNP is really high, the beneficial effect is hard to tease out. If we look now at Galactic, a positive trial of omecamtiv mecarbil compared to placebo in patients with HFrEF across a full spectrum, inpatients and outpatients, what we see here is that the benefit appears enhanced at the lower ejection fraction spectrum, which led to that original 5 other recommendation that perhaps when there's very, very low ejection fraction or low blood pressure, which was a very low exclusion criteria in Galactic. They really included patients down to a low systolic blood pressure. So in that group, perhaps if the patients are still symptomatic, we should consider omecamtiv. And in patients with recent worsening heart failure with not too high an NT-proBNP, perhaps we should be considering vericiguat. Now, let me put it all together in a very recent publication from the Heart Failure Association of the ESC that really recognizes that we need to tailor our approach according to the patient sitting in front of us, according to his or her blood pressure, be it low, normal, or high, according to their heart rate, whether or not they're in sinus rhythm or atrial fibrillation, whether or not there's chronic kidney disease or hyperkalemia. And a last group that they considered is a pre-discharge patient, which represents an optimal opportunity to optimize therapy. Using this approach, first thing to notice is there is a core group of medications in the middle that all should receive unless there's a contraindication. But then, and this gets very interesting and beautiful as this thing fans out beautifully, where we consider the different patient profiles. Now here, I know it looks perhaps a bit complicated, but it's actually a very practical approach where, for example, I'm going to look on the upper top 3 circles where regardless of the blood pressure, whether it's above 90, below 90, or in the normal range. If the heart rate is high, you can see that ivabradine, for example, is highlighted to be included on top of the main medications that are in the middle of the circle. And so this is a practical approach that I'd encourage everyone to look at. But ending finally with the spending function. Now I'm spending little bit of time on this only because this is still a manuscript that is under review, so not published yet. So I only want to share the concept of it, and that is to look at each patient coming into our clinic as having some reserve accounts. They've got a reserve of blood pressure, of heart rate, of renal function, of potassium, and even of plain money and cost. And it is our duty as heart failure physicians to help these patients to spend from their reserve account optimally to achieve the greatest return of investment. If we underspend, then they have limited benefit. We're not helping that patient much. If we overspend on one account, like on blood pressure, that means we use up all the blood pressure reserve with, say, one class of drug only, and therefore then deprive the patient of all the others. We're also not helping the patient to achieve optimal spending. And in this sense, it would help in a personalized approach, perhaps, with each patient, and then keeping this chart in mind that we have different medications that draw from the different banks in different ways. And these are listed for you here. It's quite noticeable that classes such as the SGLT2 inhibitors really have quite a neutral effect on blood pressure, heart rate, GFR, and potassium. If we look at ivabradine, for example, very neutral effect on blood pressure, which is the bank that's most limiting in many cases. So with that, just thank you very much. And I'd like to hand it over to Dr. Michael Bohm to now really talk further about the approaches that we should be taking. Thank you.
So thank you very much, Caroline, for introducing the next talk, and I would like to start and give you a perspective of a personalized approach in heart failure in patients, and in particular in the new guidelines and in the new recommendations who just were presented at the Heart Failure Association meeting in Florence. So these are my disclosures, and I would like to make 4 points. The principle, then time matters, which is important and has been mentioned by Professor Lam already, how to treat and how to individualize. Yeah, and this comes along with the spending function you just heard about. So the principles are that there are mediators which are involved in the progression of the heart failure syndrome, and involved in the progression of left ventricular dysfunction. And these mediators, of course, can be addressed by our standard therapies, and these are ACE inhibitors and ARBs, beta blockers, and mineralocorticoid antagonists. And it has been shown that when other mechanisms come into play, like heart rate reduction, and you heard about that, then there is another reduction of outcomes taken in subgroups where heart rate and sinus rhythm is above 70 beats per minute. Then there is another 18% reduction of outcomes, and this is important, and this is independent of neuroendocrine activation, as resting heart rate, which is here meant as an inclusion criterion, is more or less also influenced by genetic background rather than neuroendocrine activation. And then, in addition to that, there is not neuroendocrine antagonism for the maladaptive mechanisms, but a strengthening of protective adaptive mechanisms by neprilysin inhibition. Then you can see another 20% reduction of outcomes. And you can see, regardless or dependently on what mechanism our individual patient play a dominant role, that there might individual efficacy of different approaches. However, so what we know, and this is an interesting study of Professor Komajda, that it makes sense to combine all these mechanisms and drugs. As you can see, the more intensively these drugs are combined, the greater is the benefit. And you can see involving here the ARNI or ivabradine, it comes to a 60% reduction of cardiovascular deaths. And you can plot here also heart failure hospitalization, and both of it, there is an increasing benefit the more of these mechanisms are combined. Now, what about novel drugs? And among them, of course, are the SGLT2 inhibitors, and we have 2 trials which are rather very much in agreement. This is the DAPA-HF trial and the EMPEROR reduced trial. And what you can see that there is a 26% or 25% benefit. And what is also important, and that relates to what has been said before, that the start of treatment occurs very early on here, and within 28 days, the combined endpoint is positive, and even 14 days for heart failure hospitalization. So there is another mechanism, although we do not know exactly what these mechanisms for SGLT2 inhibitors are, which might add in addition to that. And again, which mechanism indeed is occurring in which patient, there might be an individualized relationship. So what do guidelines do? This is the old guideline. They had a very strict and very conservative sequencing. In the 2008 guideline, it started with ACE inhibitors because that was done in the SOLVE trial, more or less behind an empty background with some diuretics and digitalis. Beta blockers were then tested on the background of ACE inhibitors, mineralocorticoids on the both of them, and ivabradine in the subgroup. And this was changed then in the 2012 guidelines, where the CVS3 trial showed that it does not, there is no preference of starting either with an ACE inhibitor and the beta blocker. So 2 of them, the combination is either good, but still there is a very strict conservative sequencing of these drugs. Now we have new data, some of in patients with preserved ejection fraction or mid-range ejection fraction, and the pioneer data, and therefore I would like to make the point in the following times matter. So this is another study which came along with the first publication of the Paradigm study. And what you can see here in this paper, the early start of effectiveness of sacubitril valsartan. And you can see after 20 days and even before, the curves clearly separate. And there is an early treatment start with the ARNI in patients with chronic heart failure, and the same holds true here for SGLT2 inhibitors. So therefore, postponing treatments indeed might cause events. However, starting with all of them early, as you have seen before, might cause inadherence to treatment and also potentially adverse effects, limiting the implementation of the drugs in clinical practice. So now what is the new approach? It could be combining early. And the problem with this is that along the patient journey, you have the high mortality here in the hospital, a rather high death rate for heart failure after the hospital in the post-discharge vulnerable phase. And then you can see here that in the chronic phase, according to the long period of time, the outcome is not good, but it is better than in the two phases before. And again, you can see that the patients' phenotypes are very different here. And the problem is that all the really successful trials, as shown here, Paradigm, DAPA-HF, Emperor, and also the beta blocker and the RAS inhibitor trials, have all been done in this late phase where indeed the patient is stable and outside the hospital. So now the first one which addressed that was a Pioneer study. Pioneer randomized patients to either enalapril or sacubitril valsartan who just recovered from decompensation. And they looked, it was not powered, as you can see here from the numbers, as an outcome trial, but they looked at the exploratory endpoint, death, rehospitalization, LVAD listing, or transplant listing. And you can see a clear separation of the curve. So starting early, which is outside the present recommendation or the former recommendation of the guideline, reduced the outcome rate, not powered notably, but resulted in a very low number needed to treat of 13. And this again shows that time matters in these individual layering. And this study showed how the effects differed according to the starting time. So you can see the treatment effect. This is a line of neutrality for the composite outcome, and this is taken from the DAPA-HF study. And you can see it appears that the reduction of events is more strongly expressed shortly after initiation of treatment. Initiation of treatment here is here depicted on the abscissa, and you can see this is particularly strong with a very almost immediate significance for heart failure hospitalization. And this is what also Professor Lam alluded to. I picked that together from all the trials. So the early start of treatment is very expressed, of course, in the new trials. That is Emperor reduced here, that is 12 days. You can see it also in DAPA-HF, but not only in the new trials, but also in Paradigm, in Copernicus here at 120 days, but also in the SOLVE trial, which is here C, where the effects become significant at 28 days. And this it means, with other words, the later the treatment starts, or the more the treatment start is deferred to later time points, the more patients get events. And so we indeed need a further treatment start. And this is a relation of the treatment start according to the previous decompensation. This is taken from DAPA-HF. This paper appeared 4 weeks ago. These patients never had a hospitalization. These patients later after 12 months, and here treatment was started within the first 12 months after recommendation. And you can see that the event rate appears to be higher the more closely patients are followed after having had an event. And furthermore, the treatment effect of the SGLT2 inhibitor is greater, as reflected by the area in between the curves. The earlier and the more close to decompensation the treatment start has been done. So therefore, this is the concept, this clonic old phase chronological, careful up-titrating, of course, taking consideration of tolerance, might relate to these Kaplan-Meier curves. This is an accelerated, and this is a really fast initiation. And the speculation is that this relates here, as shown on the lower part of the right-hand side, to a more expressed outcome. So these points were taken into the consideration in the new guidelines. This was a presentation in Florence. You can see that was a very empty room, and the data were presented by Marco Metra, the chairman of the ESC guideline committee for this heart failure guidelines. You can see a lot of empty spaces, and there were no, we are not allowed to show any detailed information of this, but this is what indeed has been recommended. And now I come to how to individualize this. First of all, the new message is to start early, as Professor Lam pointed out, already recommended in the ACC treatment recommendation, not a guideline, starting with the ARNI, a beta blocker, SGLT2 inhibitor, and MRA. And the reasons how to start is, of course, tolerance and individual patient profiles, as you have seen before. So the argument of doing so is the efficacy of these drugs after 10 to 14 days after start of treatment. All drugs could be started in the hospital, and in addition to Pioneer, there are circumstantial evidence that this indeed reduces events further, and it is not convincingly shown that a very careful up or slow titration is good for efficacy, treatment adherence. This has not been shown. So starting with many drugs, I think that is a new paradigm which is recommended in the new guidelines. And you have seen then this before. So how to sequence and individualize treatment. This is the old approach we are going to leave, and this has been cited by Carolyn Lam, which was proposed by Pecker and McMurray. And they said, okay, we can start with the beta blocker and SGLT2 inhibitors. And one argument is tolerance, because they do not do much to lowering of blood pressure. However, and also the treatment size of the effects of beta blocker and SGLT2 inhibitors. However, there is one caveat. Let's look, and Carolyn Lam mentioned this a little bit before. If a patient indeed has a low heart rate, what can we expect from a beta blocker? And I took these old beta blocker trials, and you can see all the parameters which might be associated to the risk-reducing factor of beta blockers, and that is heart rate. And heart rate is more related to this rather than the dose of the beta blocker. And this indicates that a patient who is initiated and has a low heart rate of 60, he might know why we cannot expect a big effect of beta blockers on outcomes. So therefore, this is a paper which is in press now, and Carolyn Lam referred to this already. This is a patient journey. Outcomes are very high in patients shortly after a decompensation and recompensation. However, treatment initiation is low. So how to individualize with the big four the treatment effect? And there might be what is useful, which was also highlighted in the position paper, I will come in a minute to, patient profile. And this can be blood pressure and heart rate. It can be atrial fibrillation, yes and no. And also, of course, renal dysfunction, and in extreme cases, also potassium. And here you can see that according to these profiles, there should be an early start with these four drugs. And then if still there is a blood pressure which is very low and heart rate is high, ivabradine, and in particular the combination of it, which might facilitate up titration of the beta blocker when there is in parallel the application of ivabradine, this approach might be useful in patients with low heart rate, low BP. These are patients with terminal heart failure. You might transfer them to LVAD transplant implantation or heart transplantation, and then you can layer your drugs according to these patient profiles. Now, this has already in a similar way recommended by the position paper of the Heart Failure Association, and we have seen this before. Heart rate, CKD, and blood pressure is important, and this is something you might derive from this. This is an algorithm. I've taken an example of a high heart rate and a normal blood pressure in sinus rhythm, yeah, and a GFR which is poor, below 30. Of course, ivabradine can then be given, and then hydralazine, in particular Afro-Americans, and vericiguat could be there, in particular when a patient has been in the hospital. The next example is, and also when you look here at standard therapy, of course, it is difficult to give the ACE inhibitors the ARNI when the blood pressure is 90/60. You should try it, but might be difficult. Also, the a poor renal function might be a limitation for the MRA. The next example would be a heart rate which is still high. Ivabradine could be given in sinus rhythm, and the GFR is poor. Hydralazine could be added to this treatment, and in patients after recent hospitalization, we might have the recommendation, although that was not explicitly expressed with vericiguat and all these other drugs, in particular when the blood pressure is high. So high heart rate and high blood pressure. So according to this, and these were just examples here for high potassium, then of course it is difficult to give all these drugs. Mineralocorticoids should be a little bit given more carefully, but potassium binders and new drugs might come into play. So with this scheme, you can play around to individualize your treatment start in order to find a way that the adherence, as depicted by Professor Komajda in Europe and other countries, might improve over time. So therefore, the take-home messages are that indeed the principles of recommendation will change, and they need to change. There will be an early start of guideline-directed medications who all have proven to have an early start of treatment effects, who also reduce outcomes, in particular in the vulnerable phase, where patients might benefit the most because heart failure, death, and rehospitalization is very high, and the individualization can be done according to patient profile. So time is essential for heart failure patients, and there is no reason to start treatment late. Thank you very much for your attention.
3 amazing presentations, and I certainly learned a huge amount. We have very limited time available, but if folks do have questions, please post them in the Q&A box. I do notice there has been one request about sharing slides after the presentation. I believe that the webinar will be archived and will be available for later viewing, because there's certainly a huge amount of material there. I'm to take a sort of chairman's prerogative and ask the 3 of you, is the situation similar around the world? We're very blessed to have France, Germany, and Singapore represented. So perhaps you each might make a comment about global differences.
Well, I will start. I think there is no real difference around the globe, because as you could see, the situation is more or less similar in Europe, in the US, and as shown by Professor Lam in Asia. So I think in a nutshell, the rate of prescription of medications is improving, but the dosage remains suboptimal. And I think that the key message which arises from this representation, that we need to fight against inertia and probably start very early on recommended medication.
Well, just to be a bit controversial, I'm going to say that the only difference I may highlight from Asia is our patients are even younger at the sort of manifestation of heart failure, which is really quite tragic. So the average age of our patients with HFrEF is only about 60. And so it's something that we should be even more urgent about, because these are patients with lots of productive life ahead of them and dependence.
Caroline, if I may interject briefly, one point which differentiates Asian patients from Western countries' patients is the weight. So we have to be a bit cautious when we say target dose, because target dose may be slightly different in patients who have a 60 kilograms weight on average compared to 80 kilo or plus in Europe or in the US.
So I'd like to, I'm going to try and go fast, and if we can keep our answers really tight. There's a question here. Hello from Cambodia. Can you help highlight some patient profiles that we should start BB alone, ivabradine alone, or combination BB plus ivabradine?
I think the ivabradine question comes a little bit to the patient profiling I was referring to. So in patients with a low blood pressure and a high heart rate, that is a typical case for ivabradine. Nominally, there is an increase of blood pressure by 2 millimeters of mercury in shift when heart rate is reduced. With ivabradine, there might be a little bit of difficulties with the beta blocker. So if there are difficulties to reduce heart rate with one agent alone, there is a possibility to combine ivabradine with beta blockers. for well-defined mechanism, there might be a more utilization of a contractile reserve. So heart rate, in particular at low blood pressure, is a case for ivabradine, but also high blood pressure. When blood pressure is not low enough, the target heart rate in patients with heart failure is between 50 and 60, because descriptively it was shown that these patients had the lowest number of events.
I would only add that we would need this patient to be in sinus rhythm. That's
Sure.
another thing. Yeah.
Important.
Okay. Well, another drug-related question. Any preference of eplerenone versus spironolactone?
I think, yes, there is a meta-analysis in patients with low blood pressure where they took together all these drugs, all the studies on eplerenone and spironolactone, and there was consensus in the guideline committee of the 212 guideline that this is recommended as a class effect concerning outcomes. But if the blood pressure is critically low, then it appears so that spironolactone reduces blood pressure a little bit more than eplerenone. And given the fact that this is a class effect on outcomes, then it is worth a try of eplerenone instead of spironolactone.
Actually, obviously, I'm a surgeon, so I'm not dealing with these patients, but I've certainly seen patients with heart failure. And this is a tragic condition. It's wonderful to see the advances that you folks are involved in developing and promulgating. Do we not have an obligation to get patients involved in the dialogue to improve patient education so that we have an informed patient seeing an informed doctor?
Well, I think I alluded to this at the end of my presentation. I think that patient education is one of the pillars to improve the situation. Together with disease management programs, we have to organize the discharge of our patients and ensure that they will be followed up carefully and early on.
Jonathan, if I may, I would elaborate to say that even patients and their families need education. So where I'm coming from in Asia, there are a lot of patients who sort of don't want to know about their condition in the older generation and are extremely dependent on family and children. This is rapidly changing. Our society is also rapidly aging. So I think a holistic approach, you're absolutely right. It's very important, often gets neglected though.
I always like to say to patients, what part of it's your healthcare do you not understand? It's your healthcare. You have that obligation. We are running out of time, and that wraps up our question and answer session. And in a moment, I'm going to ask our panelists for a single sentence summarizing their key takeaways. While they formulate their thoughts, though, I want to thank them for taking their time to share their expertise with us, and also for all they have done to advance the science and all they've done to help patients, because let's face it, we're all patients sooner or later. I also want to thank Servier for their kind support of this educational activity, and EMG Health for managing the technical aspects that I personally find so challenging. So hopefully that's given you enough time to come up with something pithy. Professor Komajda, you first. What's your key message that people should take away?
Disease management program with multidisciplinary approach, including nurses, families, and patients who should empower their disease.
Fantastic. From Singapore, Professor Lam.
Treat quickly and treat well. And it's important that we have a personalized approach. So please listen to Dr. Michael Bohm.
And with that, Michael.
Please follow the guidelines, which now have done an important step for early recommendation of treatment, and fight hard for every drug and every dose you can give.
That's so eloquent. Well, this simple chap has certainly learned a lot today. Thank you very much. And finally, thanks to our audience for taking the time, dedicating their time so that they can better help the patients that we all serve. So for now, everyone, stay safe, stay well, stay curious. Bye for now.